All right. Hello, everybody. Uh, I'm Dr. Saundra Stock. I'm at the University of South Florida, and I'm going to be talking to you today about updates in the treatment of pediatric OCD. I think we last reviewed updates on this in 2018, and so I've just looked at the literature to see if there was any changes recommended in terms of treatment for OCD. So what's new in terms of treatment for OCD? Well, there's some interesting you'll see this in anxiety as well, that there's stepped care studies out there, having people do telephone delivered CBT. So one study where instead of having the patient in person in the office, they did CBT over the telephone, and they found that to be non-inferior to face-to-face CBT. So kind of nice, these stepped care interventions looking at access to care issues. They also found that an internet delivered CBT program where families were mostly, doing the lessons on their own with like scheduled, let's say 30 minutes once a month with a therapist to kind of check in and see how you're doing implementing, what you're learning about, that an internet delivered CBT program for OCD was superior to a wait list. So again, addressing some access to care issues that families can indeed benefit from CBT delivered in ways other than face-to-face. I think the difficulty is finding who can do this telephone delivered CBT and finding the kind of online modules. That's a challenge, but that if somebody has those, has access to those can be helpful. There was also a study where they did group CBT for one set of patients, and a different set of patients started fluoxetine. So their first step, they got randomized to either group CBT or fluoxetine, and found that they did about the same in terms of their first OCD treatment step. So really they could be started with either one, and then they crossed over into the other, could have the other intervention added. Number of studies looked at kind of what predicts treatment response, and found, which I don't think is a surprise to anybody, but found that higher avoidance symptoms at baseline predicts more difficulty in terms of response, less response to treatment, less improvement with treatment. There was this cohort in the Netherlands study that gets called Nordlots, and there was a couple studies published with that in the last 4 years, where the Nordlots cohort is a 269 youth that got 14 sessions of CBT. They looked at the 54 patients who did not respond to that first intervention and randomized them to either continue in CBT or to get sertraline in between 100 to 200 milligrams per day, and look to see, and both groups did well, but what was published more recently was looking at a 3-year outcome, 3-year treatment outcome. So the interventions had stopped, but they looked at them 3 years later, and 90% of the kids had responded and 73% were still in remission. So sort of showing that if you get effective OCD treatment, however you get that, either through CBT or combination of medication or medication alone, that really the remission can stick for 3/4 of the patients basically they remained in remission, which is good. And we do know that childhood OCD is a little bit different than some of our other disorders, where childhood OCD has a better prognosis as compared to adult onset OCD. So, like we think about like childhood onset depression, we think about maybe having a worse prognosis than adult onset depression, or being more persistent. But at any rate, childhood onset OCD has a better prognosis than adult onset OCD. So that was just kind of showing that getting to response and remission sticks for the majority of patients. And there was one study looking at N-acetylcysteine, a pilot study where they were trying to recruit kids ages 8 to 17. Unfortunately, only 9 kids got into the trial, and they had low recruitment and they stopped it. They were titrating them onto N-acetylcysteine 900 milligrams 3 times a day over a 3-week period of time, and saw a small signal that maybe this was effective or was helpful. I think the patients were they were allowed to be taking stable medications, so they could be taking, let's say, ssris, but just no changes in the prior 12 weeks to starting the N-acetylcysteine. This is a pretty similar dose to some of the studies that we've seen recently with autism and irritability, and seeing NAC cause some improvement for autism and irritability. as well as seeing it for like skin picking, seeing it some help with reducing, cravings for cannabis. So NAC is a very interesting substance. Unfortunately, it's getting harder to find. There's discussion about making it a prescription only medication. Right now, you can get it over the counter. You have been able to get it over the counter, but it's been increasingly difficult to find in the past 6 months or so. So, but that's another something that was studied. So, looking at adults, there has been some new treatments for more treatment, some treatments looking at different kind of novel modalities for adults with OCD. So there's certainly been plenty about repetitive transcranial magnetic stimulation, some different protocols for that, like low frequency over the supplementary motor area as a treatment intervention for OCD. There were 2 randomized controlled trials of memantine showing some improvement, which is interesting. There were some trials with lamotrigine, topiramate, and riluzole. Those are all more medications used in neurology. Some of the smaller studies had positive results. Some of the larger studies had mixed results or weren't effective. So hard to say for sure if any of those are very effective for OCD, but those are definitely things that people are looking at for adults that can't take SSRIs, or adults who haven't responded to SSRIs, or SSRIs and antipsychotics if they haven't responded to those, looking at other medications. Some small studies with the direct current stimulation, TDCS, some studies with deep brain stimulation. And obviously we know that ablation surgeries can be helpful for treatment refractory OCD. Certainly the ablation surgery we're not studying in kids. I don't think people are really studying any of these other things in kids very much. Interestingly enough, ECT was found not to be effective in adults who have OCD. And there was some discussion about different modalities for OCD using EMDR versus CBT, and no difference was found in a small trial looking at that. So that's kind of what's new for treatment, OCD treatment for adults. So if we look at treatment recommendations for youth with OCD, really no changes. I didn't recommend any changes really. We've got level 0, a comprehensive assessment that includes screening for OCD symptoms and medical causes. We want to characterize the symptoms of OCD and characterize any comorbid conditions like OCD, like ADHD or depression or an anxiety disorder. Level 1A, if there's mild to moderate OCD, we recommend starting with cognitive behavioral therapy plus an exposure and response prevention component with a qualified therapist, if you can find that. And if it's moderate to severe OCD, starting with a combination of the cognitive behavioral therapy with exposure and response prevention and an approved SSRI, and an SSRI that's approved to treat OCD in youth this age, which would include sertraline, fluoxetine, and fluvoxamine. Level 2, if there's mild to moderate OCD and they have an inadequate response to CBT alone, at least 15 sessions, then add one of the SSRIs that's approved to treat OCD in kids, sertraline, fluoxetine, fluvoxamine. If they have moderate to severe OCD and an inadequate response to combination therapy of CBT plus SSRI, after 10 to 12 weeks of that, we want to make sure, well, after 10 to 12 weeks of the optimized SSRI dosing, consider switching to a different approved SSRI. Level 3 would be if there's an inadequate response after 10 to 12 weeks of an optimized SSRI dosing, that you could switch to a different SSRI, or maybe switch to clomipramine as monotherapy. Or level 3B, consider a non-FDA approved SSRI like escitalopram or different SSRI. And level 4 is to reassess the diagnosis and refer to a specialist, as well as if there's treatment resistant, if the person is treatment resistant to behavioral therapy and or resistant to an SSRI, you might want to augment with low-dose aripiprazole at 0.5 to 3 milligrams a day, or augment with clomipramine 10 to 50 milligrams per day in conjunction with the current treatment. So we've got some notes we have in the booklet to people, or in the PDF online to people, that the standard course of CBT with exposure and response prevention is 10 to 15 sessions, 20 sessions if the treatment is refractory. That with OCD medication, the time to reach full effect may be longer than for depression, like 8 to 12 weeks, and there may be, you know, less response. I may need to push the dose higher. Doesn't say that there, but it's sort of implied. And that the ssri efficacy may be less when it's in the context of another comorbid condition, such as tics. People who have tics, people who have tics tend to have more treatment refractory OCD symptoms, and kids who have comorbid oppositional defiant disorder may also have more difficulties attaining remission through treatment. In patients who have tics and OCD, they may need combination pharmacotherapy, such as adding in the D2 blocker earlier in the treatment course with the SSRI. Really, there's been very few trials looking at kids who have both OCD and tics, and that most of the data exists for risperidone and aripiprazole in low doses. And there's a dosing table, and no changes. No changes to that, other than, I think I just said we don't need to be saying no approval for OCD in children. You take out the in children. I don't think escitalopram is approved for OCD treatment in adults either. I can double check that though, because that's one asterisk was no FDA approval for OCD, and then 2 asterisks was no FDA approval for children. But we can double check that. So, but otherwise, nothing really that I would say suggests a change in the table. So, okay. So again, really not a lot of new information in the last 4 years. I don't think we would need to make any changes to what we recommend in this table, you know, in this treatment. I mean, I think really these treatments are, these guidelines are really to help inform primary care, general psychiatry, people, you know, primary care providers, people who are, you know, helping to, you know, really get started treating patients, but they're not necessarily, I don't think we can go through every permutation, you know, in every kind of difficult case. I think these are for the, just kind of getting people the guidelines and the framework about how do you move through treatment, what do you consider. So I don't think that really there's been anything that would change what we're recommending. I did, for OCD and anxiety, tried to look to make sure all in the booklet, there are a lot of resources. There are websites and books that are recommended. So I went through and made sure all of the websites are what we'd recommend. I'd recommend linking to ACAP's resource centers, and tried to look around for any online therapies that we could recommend. I did not find ones for OCD. So if anybody happens to know of those for OCD or for anxiety, online therapies that are accessible to everybody, we can certainly talk about that, because we'd like to make sure we've got some of those resources available to folks. So, all right, look forward to talking to you.